All right. Hey, welcome everyone. Thanks for taking the time to join our webinar today. We'll jump right into the topic at hand today. And before we get in there, I just wanted to mention a few things, some housekeeping things, but many of you know who we are, well, who Wellvation is, and we provide, wellness programming, strategy, ideas, things like that for our clients, the Manage Well Wellness platform. But along with that, we've had a really close relationship with Mayo Clinic, I think going on 17 years now. And many of the resources that we provide to our clients, as many of you know, either originated from Mayo Clinic or we've created them in collaboration with Mayo Clinic. And we've recently started this quarterly webinar series to share some of the expertise behind some of the offerings that we have and the tools that we've created in connection with Mayo Clinic. But a topic that's on the mind of many these days is preventing burnout in the workplace. And it's of particular interest, of course, to healthcare organizations. We hear it in that context all the time, but certainly not limited to healthcare. It's really a concern across a lot of industries today. And so our topic, of course, today is preventing burnout and how to thrive in this environment that we're all working in. And so I'm excited really to introduce you all to Dr. Colin West. Dr. West was originally from Seattle, and he received his MD and his Ph.D. in biostatistics from the University of Iowa. And in 1999, I believe it was, he completed his residency and chief residency in internal medicine at Mayo Clinic and joined the faculty in general internal medicine in 2004. He is currently professor of medicine, medical education and biostatistics at Mayo, and he is director of the Mayo Clinic program on physician well-being and was named the first medical director of employee well-being for Mayo Clinic in 2022. Dr. West's research has focused on medical education and healthcare professional well-being and has been widely published in many prominent medical journals. And throughout the course of the webinar too, our chat function should be enabled. So if you have questions, please use them, submit them in via chat, and we'll get to as many as we possibly can. There were some questions submitted on our registration for the webinar, and we'll get to as many of those as we can as well. So with that, Dr. West, thanks for being here and welcome.
Thank you so much. I'm delighted to be with all of you. So what I'm going to speak with you all about here today is really how we try to turn our conversation from the common narrative around burnout and other dimensions of distress to truly what we're aspiring to, which is thriving and flourishing in the challenging work that we do. I come at this from a healthcare perspective because that's the work environment that I'm in, but actually these principles apply beyond healthcare to any work experience. My contact information is here. I'm going to put that on the last slide when I'm done at the end of the talk as well. Happy to engage with folks on email or various social media venues. I don't have any disclosures or conflicts of interest for this material. And I will also point out that I have for more than 4 years now posted a weekly well-being thread on various social media networks as well, which digs into different aspects of the literature, leadership components, key figures in the field, and so on. For today's session, though, there are 3 main learning objectives. We're going to talk about some foundational elements, the scope of the problem, the background descriptive situation. We'll talk about the epidemiology. So what are the contributors to workplace challenges? And then why does this matter beyond just having good learning and working environments for us as individuals? That's important in and of itself, but there are a host of other consequences which elevate this in importance. And then finally, what do we understand from an evidence-based perspective around approaches to prevent burnout and even go beyond that, promote well-being, help people learn and work within environments that support their ability to thrive and flourish. So let's dive in. The pictures on the screen here illustrate what we hope to experience in our learning and working environments. These are healthcare examples, but extend this to any working environment, really. We would like to have positive, relationship-based interpersonal interactions. This is really fuel for the human spirit. And we all recognize that often we are able to achieve these kinds of experiences and this dynamic in our work environment, but we often fall short of this as well. Our patients, our colleagues, depending on our work environment, our clients or customers, bring their own baggage, if you will, to the interactions, their own individual circumstances that sometimes are not conducive to positive interactions. We bring our own experiences and issues into those dynamics. And sometimes they don't align to allow us to have this kind of positive experience. But it's important, I think, to reflect on how often we are actually able to have this dynamic. And as we think about pointing toward well-being, what do we really mean by that? And so it turns out it's somewhat difficult to come up with a quick, easy definition for well-being that everyone will agree upon universally. But my working definition is holistic. Well-being is the state in which an individual can achieve their greatest desired potential as a complete human being. And this has guided some of the work that we've evolved Mayo's couple decades in this area further in the last 2 or 3 years since I was named the medical director for employee well-being for the entire Mayo enterprise. On the flip side of well-being, we hear a lot about different dimensions of distress. And one of those for specific conversation today is burnout. This term has become colloquialized. It's become part of just standard lingo in a way that has drifted somewhat from its actual definition. People will talk about feeling burned out when they just didn't get enough sleep, or they had an argument, or they had a stressful moment at work. Those are moment by moment experiences. They're not actually burnout. So what is burnout? Well, as cast by people doing decades of work in this field, like Christina Maslach and others, burnout is a work-associated phenomenon with 3 main dimensions. They are emotional exhaustion, depersonalization, and a sense of low personal accomplishment. These are measured in a somewhat complex way on continuous scales that defy a simple composite. But if any of these experiences are felt once a week or more, we have linked that with the important consequences that I'll highlight in a couple of minutes. What are these then? So low personal accomplishment, I'm not going to say a whole lot more about after this slide, because in our early work, it wasn't as strongly associated in healthcare with the external consequences. We need to put a pin in that because work in recent years has linked burnout and associated outcomes with imposter phenomenon, low self-valuation, and other factors that closely relate with low personal accomplishment. From the very beginning, emotional exhaustion and depersonalization have been closely linked. So what are those? Emotional exhaustion is illustrated by this statement that comes from the Maslach Burnout Inventory, what most regard as the gold standard for the assessment of burnout. I feel like I'm at the end of my rope. This is emotionally having nothing left to give, feeling husked out in your ability to tap into emotional reserves to help meet the needs of your patients in healthcare. And again, if this is experienced once a week or more, that's associated with a host of key consequences. Depersonalization is illustrated by this assessment statement. I've become more callous toward people since I took this job. This is treating other human beings as objects rather than fully formed human beings. This is becoming hardened toward their experiences in their lives. And in healthcare, I think it's intuitive that this is antithetical to every professional ideal that a healthcare professional holds dear. And it's certainly not what patients want or need in their interactions with our healthcare system. But again, if this is experienced once a week or more, that is linked to important consequences. So how common is this experience? Well, if we look at experiencing either emotional exhaustion or depersonalization at least once a week, what we see dating back to national studies in 2011 is that things kind of bounced around the 45 to 50% range for overall burnout, shown in red on this slide. The 2020 numbers come from the fall of 2020, 6 to 9 months into the pandemic. And interestingly, we actually saw the lowest measured levels of burnout at that time. And initially, that might not make sense to you. But as we get into talking about drivers, what I'd like to impress upon you to think about further is that, in fact, in the early phases of the pandemic in healthcare, people were leaning into deeply meaningful work. And that was protective against burnout in the short term. It's not sustainably protective, however. And we measured again, not in 3 years, but in 1 year. And what we saw at 1 year later, in the midst of the pandemic as it persisted, was the rebound. And we saw there that among physicians, and in fact, for the first time at equal levels among other groups in healthcare, burnout levels that were in excess of 60%. And in certain groups, emergency medicine physicians, critical care nurses, we saw burnout rates exceeding 80% of those populations. So this is a common issue, which is important because in the early days of this work, one of the common reactions to discussions about burnout or distress in healthcare was to suggest that this was an individual deficiency and that maybe these people either weren't resilient or tough enough for the careers they'd chosen, or they had chosen the wrong careers entirely. And I think that becomes a misnomer when you're talking about 40, 50, 60, maybe even 80% of a field dealing with these concerns. Why does this matter beyond the individual experience? We all should expect positive growth, inspiring work environments. Well, if you're a patient, healthcare worker burnout is associated with medical errors, suboptimal professional behaviors from your healthcare team, reduced patient satisfaction, especially in the long term, and even experiences with implicit and explicit racial bias. We are not our best selves. We cannot do our best work when we're dealing with burnout and distress. There are also access and healthcare system considerations because burnout is associated with staff turnover and reduced clinical hours. The pandemic cast this in a stark light because there were staffing issues across all professions, including healthcare, and we were already dealing with a limited buffer. And so we're continuing to dig ourselves out of that across healthcare as the demands of a population that continues to have escalating healthcare needs do not roll back. And yet people have looked around after the pandemic and thought, well, maybe I do want to look for something different. That's really difficult for managing a healthcare system. It's hard for patients to access the care they need, and it's not satisfying for healthcare professionals themselves. We also know that healthcare professional burnout and distress is associated with reduced acquisition of medical knowledge. In fact, for medical residents, those with burnout perform on standardized knowledge assessment tests an entire year of training behind residents who don't have burnout. Mental health issues are associated with distress, and even some public safety concerns where, after accounting for fatigue, burnout was associated with motor vehicle crashes and near misses. So a lot of reasons to care about this. This is also expensive. So if we just think about physicians and we just look at the costs associated with burnout-related job turnover, so none of these other consequences on the slide. This has been estimated in a study we did with the Harvard Business School a number of years ago to cost the US healthcare system about $5 billion a year, or $7,600 per physician per year. And I mention that for those of you that may work in larger healthcare systems or have leadership connections. These are costs that do not appear in the budget for any organization at present. So we are paying for this without accounting for it right off the top every single year. And this doesn't include nurses, desk staff, all of the other healthcare members of the team that are essential to our ability to offer appropriate care for our patients. So this is a very, very expensive issue. And when we start talking about solutions, keep this in mind, because sometimes we hear we'd love to address well-being if only we could afford the investment it would require. And that's looking at things the wrong way, because it's not that we can't afford to invest in well-being. We can't afford not to invest in well-being because we're already paying substantially for that. So again, when we look at the demographics, we have more than 100,000 medical students, residents, and fellows in the physician training pathway, 500,000 practicing physicians, more than 1 million nurses, and countless other healthcare and biomedical science professionals dealing with burnout in public health. So we've cast this as a public health crisis, and we've also emphasized the framing that whether this is an individual or system problem primarily is rhetorical. Because with these kinds of prevalence figures, this is not about individual deficiencies primarily. Now, how does this inform a path forward then? And thankfully, we do have a roadmap for this. Because in 1999, the Institute of Medicine, what is now the National Academy of Medicine, released To Err is Human. And every year I work in this field, a decreasing number of people are familiar with this document, but it was a critical inflection point in quality and patient safety. I'm going to exaggerate slightly, but prior to this document coming out, the most common approach to dealing with an error was to try to assign blame and identify who the individual was who was responsible for the mistake. And in medical circles, there would be an M&M conference where that individual would essentially be humiliated. And the idea was they would never make that mistake again, having had that experience. And everyone in the audience who is cringing by association would be even more dutiful in their efforts to avoid errors. To Err is Human came out and said, wait a minute, the vast majority of people in healthcare are dedicated to the welfare of their patients. They want great outcomes, and yet mistakes still happen. So what is it about the structures within it which care happens that allows mistakes to persist despite these best efforts and intentions of the human beings involved? And we need to think differently about our system and our structure in protecting everyone from human fallibility. As Deming said earlier in his career, 85% of the reasons for failure relate to systems and process. Fix the workplace, not the worker. Paul Batalden at IHI has said every system is perfectly designed to get the results it gets. So when we think about errors in quality and safety, or we think about burnout among healthcare professionals, our system is perfectly designed to deliver those outcomes. And on the one hand, we can sort of wallow in negativity and let that be an indictment of our current structures. Or, as I prefer, we can turn this into an opportunity and say, wait a minute, what this means is that if we perfectly design the system around well-being, we can get the results for ourselves and our patients that we want. And you can extend that outside of healthcare as well. The business world, in many respects, has understood that if you take care of your employees, they will take care of your business for many years before healthcare has paid attention to this. But again, we design our learning and working environments to deliver the results that they should deliver. And we can redesign things around those outcomes if we are intentional about it. So at the 30,000-foot view, one of the simplest models to think about distress or engagement at work is the job demands resources model. And this stipulates a very simple equation. Distress results when there's a chronic imbalance between high job demands and the resources that are available to allow people to meet those demands. In healthcare in particular, the trick in looking at this equation is to note that the demands of the work in healthcare are always high. We get really good at making very complicated decisions seem simpler than they are. But there is a cognitive load behind those decisions as we think about side effects, costs, interactions with other medications, recovery periods, the patient's ability to heal based on their other comorbidities or their social situation. Those are constantly in the background of even the most straightforward seeming decisions that we make. And so we need our resources to match that high level of cognitive demand. And yet in healthcare, what we often see that we're asked to do more with less. And this is true in other industries as well. If we can reduce demands by having new technologies offload some of that burden, then maybe we can get away with fewer resources. But until that happens, if we reduce resources, we're simply going to tilt this equation predictably in the direction of burnout and distress. And that's what's happened across medicine all too frequently. When we think about human performance theory, we have really a homeostatic mechanism. On the left is the Yerkes-Dodson law. I'm not going to talk about the simple task part of this curve because in medicine in particular, things we do aren't simple. For difficult or complex tasks, the Yerkes-Dodson law, which is more than a century old, identified with low levels of stimulation, performance can be limited. And we actually respond to stimulation. We respond to that challenge by improving performance up to a point. But if that stimulation or stress is sustained for too long at too high a level, human performance starts to decline and we get diminishing return on investment. This has physiologic analogies in medicine. At the center here is a variation on the Frank Starling curve for cardiac function. And what we see is that if filling pressures in the heart are low, stroke volume or cardiac output or function is also lower than optimal. But by the same token, if we overstretch the individual fibers, the sarcomeres in the heart, we actually also don't get optimal function. There is a point of maximal performance that is actually short of the maximum cardiac load or pressure that we could put on the system. And human stress response is exactly the same. We respond to challenge favorably to a point. In fact, in healthcare, we chose this profession in part because we find that challenge stimulating. We want that challenge to an extent. But when it is sustained at too high a level for too long a period of time, the stress response curve for humans means that we progress beyond fatigue to exhaustion and our performance starts to decline. And so to optimize our performance, here illustrated in medicine, but in other job roles as well, we need to intentionally shift our place on the human performance curve to deliver optimal outcomes. With that as background, let's talk a little bit more specifically about the factors that drive burnout in particular. I mentioned Christina Maslach earlier. Work that she's done with Michael Leiter has identified 6 areas of work life that can drive engagement if they're more favorable and drive burnout and distress if they're less favorable. These are not rocket science. We could all sit down for 5 minutes and come up with these 6 domains, but they are backed by 4 decades of research. Workload is the first. And again, in medicine and in many other job roles where we thrive on the challenge, this is not about working 20 hours a week or having Friday spa day. This is about having a sustainable and manageable workload. This is about trying to avoid what some in healthcare have found regularly working 70, 80 hours a week of cognitively incredibly demanding work with limited vacation or time off. And even when we do take vacations, we've got electronic medical records and direct pager contacts, no matter where we are on the surface of the earth. Control and autonomy is important. We need agency in the decisions that affect us. Intrinsic and extrinsic reward. Intrinsic reward is the meaning, the sense of purpose from the work that we do. I'll come back to that. Extrinsic reward is partly about fair compensation, but that's not all this is. This is also about being appreciated, acknowledged, and valued for the contributions that we make in non-financial ways. Being part of a community, being part of something larger than ourselves, feeling connected, feeling like we belong to something larger than ourselves can be very favorable in building learning and working environments that allow people to flourish. We need to be treated fairly and with respect, and we need our individual values to be reflected in what we see in our environments around us. If there is a discord between our individual and organizational values, that drives tension and distress. This has been modified for medical environments in particular, because Maslach and Leiter did not specifically work in medical fields. In fact, that wasn't the focus of most of their burnout work. But in medical areas, we really have kind of the same general dimensions with some particular highlights. So in the upper left here in green, efficiency and resources. In medicine, we immediately think about the electronic medical record. We think about documentation burdens. We think about prior authorization and order entry and all of these things that are indirectly related to taking care of our patients, but require a lot of distracted effort away from focusing directly on the patient in front of us. When those are efficient in translating our plans into action, physicians and other healthcare professionals are on board with these tools. When they pull us away from the patient, and in some cases actually make us feel like the computer is our primary patient and the actual human patient is off to the side, we really feel like that's a threat to what matters in the work that we do. And that leads to various dimensions of burnout. At the center of this is meaning in work. The work that we do needs to matter. And in healthcare in particular, that should be fairly obvious. The work that we do should intuitively matter because it's right in front of us, the effect that we can have on helping people live better lives. But when other factors come in and distract us from that connection, we become disconnected from it. So I actually expand meaning in work to what I call the MVPs of well-being: meaning, values, and purpose. And every effective solution for well-being, in medicine in particular, but I think probably in other professions as well, is really about connecting us in some way more effectively with one, if not all, of meaning, values, and purpose in the work that we do. Something as simple as AI-assisted documentation, which is becoming a major wave across medicine. How does that work to promote well-being? Well, it's not just because it saves people time and they don't have to type as much in their documentation because there's an assisted scribe that's prepping their note in an AI-supported way. It's actually because it allows us to refer our attention more intentionally on the patient. And that's what is most meaningful in the work that we do. That's our purpose.
Dr. West, do you find
Yes.
like sometimes the introduction of new technology in the workforce can be a contributor to this too? I know some folks struggle with, having to adapt to a new piece of technology, Microsoft Teams, for example, although we were an early adopter. But how's that contributing, like, especially as it relates to, adequate training? And I imagine it had to be a huge issue when EMRs came into play.
No question at all. So this is actually a double-edged sword because if new technology comes out and the training that's required to allow us to use the technology requires us to change our fundamental practices and pulls us away from patients, we really don't like that. On the other hand, if these are user-focused sorts of entities, and the EMR has not done that, the user experience for the EMRs has not been good. We've studied that. It's quite poor, actually worse than Excel, which is commonly pilloried when people talk about tech. If, however, there are technological advancements where it's very clear that this is built around improving our ability to focus on what matters, physicians and other healthcare professionals actually embrace those technologies. We work with fancy technology every day in what we do. So there's a misnomer out there sometimes that healthcare professionals are technology averse. I don't think that's true. I think we are bad technology averse. And like Charlie Brown trying to take a swing at the football, we have felt like the tech developers are Lucy, and they've pulled the football back so many times that we're a little cynical as a profession about the next wave of latest, greatest tech that's going to help us do our jobs better. So it's incumbent on the rollout, the change management strategies around new technology, that these really fundamentally at their core be built around the user experience with an understanding that at the center of the user experience is our ability to connect with what matters most, which for most of us is that direct interaction with patients. So again, tech is not inherently bad, but when it is rolled out in a way that pulls us away from what matters or takes even more time for us to retrain in ways that do not deliver good dividends after that initial investment, that unfortunately fosters and promotes the cynicism that some healthcare professionals bring to technology. I mentioned ambient scribing as an example because I actually think that's a great example of potentially a more positive way forward on this. And I say this fully mindful that Lucy might be sitting there ready to pull the football away as we swing our leg through. But I think the difference with things like ambient scribing is that it is fundamentally designed to integrate with care interactions with patients. So it's not a separate thing. It's clearly embedded and integrated in a way that it's not intended anyway, to pull the physician or other healthcare professional away from the patient. It's intended to work in the background to support and facilitate our ability to focus on the patient. That is fundamentally different from many other tech rollouts over the last couple of decades. All right. As we get a little bit more specific, there are both individual and organizational strategies to promote well-being. That may seem a little strange because I just spent 10 minutes ago discussion around this being more of a system problem than an individual problem. But it is not individual exclusive. We do have an obligation to bring our best selves to our work to the greatest extent possible. And sometimes what is within our sphere of influence is more in the individual sphere than larger. So we can't ignore the environments that we're in, but we can pay attention to doing our best with what we can control. So what are some of those individual strategies? Well, integrating values, seeking meaning, and reminding ourselves of the meaning in the work that we do are critical. As we get into the mundane aspects of just the grind of day-to-day work, it is very easy to lose sight of the impact that we're having on other people's lives. We don't just take care in medicine of the patient in front of us. We take care of their family. We take care of their loved ones, their community. There is a ripple effect if we allow ourselves to see that. And that's incredibly powerful because the meaning in the work that we do is intrinsic, but it is easy to become disconnected from that. We're also not able to connect with that if we're not taking care of ourselves from a self-care perspective as well. So exercise, sleep, everything that we advise to our patients and don't do very well ourselves actually is important. How do we nurture relationships in our personal and professional lives? For some people, it's about hobbies. It's about spiritual practices, mindfulness. It's different for everybody. But it's important that we reflect on what is relevant for us, for our own self-care, that fills our cup in a restorative way and allows us to bring our best selves to our work. This also requires that we calibrate our distress levels because we're not very good at assessing how well we're actually doing. Despite sometimes complaining a lot about what we're dealing with, we're not very good at figuring out where we are relative to our colleagues, and we'll think that we're doing better than our colleagues when that is really sort of lying to ourselves. So there are tools out there to help with objective self-assessment. I'm not going to say a ton about these. The resources are listed here. And we'll work on making resources or slide sets available, and my contact information has also been provided. But there are tools out there to allow objective self-assessment. The Wellbeing Index is one such tool. It was developed at Mayo. I am not personally connected with the development of this instrument, so I don't have a disclosure or a conflict to share. But this is what feedback might show if someone filled out the very brief set of questions with normative benchmarks for, in this case, other physicians, but it also has other job roles in medicine as well. And this can allow someone to look across the dashboard and say, work-life integration, I'm not very happy with how that's looking. Maybe I need to put some more attention into that. Whereas on the far right and the upper row here, severe fatigue, I'm about average there. I could do better, but maybe that's not as important to me right now as work-life integration. Or the converse might be true. You know what? Work-life integration, it's not good right now, but I want to focus on fatigue. I'm going to really put some attention there. I'm not going to say much more about individual strategies because there's a risk of promoting cynicism here and giving people the idea that we're blaming the victims by saying, hey, you just need to be tougher. You need to bring a better self to your work environment, and we're not going to address fixing it.
Dr. West, maybe you'll get to this, but
yeah.
Are there, interventions you've seen or apps or something to help get out of burnout?
Yeah, so we're going to talk a little bit about solutions here in about 5 minutes, I think,
Great.
as I begin to sort of head down the home stretch.
Gotcha.
The nail in the coffin of some of the individual primacy here was contributed to by a study that we did a few years ago on resilience and burnout. I want to preface this by saying resilience is a good thing. This is not an anti-resilience study, but it is important to note that despite having higher burnout levels than the general population, physicians nationally also have higher resilience levels than the general population. And so what this means is that although burnout levels go down as resilience goes up, that's displayed on the far right panel of this slide, we see that even physicians with the highest possible resilience score in this study, 30% of them were still dealing with substantial degrees of burnout linked to those consequences that I mentioned earlier. So resilience is important, but it cannot be our primary focus. We need organizational approaches to improve our working and learning environments. And that aligns with what we can learn from quality and patient safety, with Deming saying 85% of this is about our system. And I should mention, later in his career, he actually revised that estimate to 94% in one of his famous papers. 94% is system, 6% is individual. So there are organizational strategies to help foster these environments that create the ability for people to connect better with thriving and flourishing. I'm not going to read the list here, but just to highlight a couple of points. First, we have to acknowledge and assess them. Putting our head in the sand and saying, well, it's just the way it is. And it's not really that bad, or it's not really that good. Either way is not informed. We cannot appropriately address a problem until we acknowledge it and assess it to know where we need to go. Leadership is essential. Community at work is important. We rise together. And we need to, at the same time, recognize that if we support people's ability to connect with what speaks to them from a self-care standpoint, and we provide space and support for people to do that, that's also part of, not the entirety, but part of the solution. So I'm going to give you some tangible examples. This is a general approach summary linked along 5 rows of categories of drivers of well-being or distress. And if we think about workload, the top row, we can look at this from an individual or an organizational perspective. From an individual standpoint, often the only way people can think to control their workload is to reduce their work effort and go part-time. It is important, especially in a current generation of work expectations, that flexibility at work be supported. People are expecting this as work integrates into the rest of their lives. But what's interesting is that many of the people in some professions, especially medicine, who are working part-time actually would prefer not to be. They are working part-time because it's the only way that they can see themselves surviving the work demands of their job. And that's an organizational issue. Why are productivity targets set where they are? Are they sustainable? And that's a key issue to grapple with, because it's very expensive for people to be working part-time, both for them because they have less income, but for their organizations unless they're self-employed, because you're still paying full benefits for many individuals who are working part-time. If we skip down to the bottom row, meaning and values, from an individual standpoint, there are decades of literature and studies out on positive psychology, mindfulness, reflection, gratitude exercises. Those are relevant. They can't be the only set of solutions because that's pushing it all on the individual, but they actually are relevant and they have a strong evidence base. Organizationally, we need to think about how we protect time for people's most meaningful activities. How do we promote community in our workplaces without infringing on people's personal lives? And how do we support people's abilities to connect with one another in their work so that their learning and working environments are more positive? I'm going to close before I take a few questions to expand any topics that may be of greater interest to people with a little bit more about how we're approaching this in the last 2 years at Mayo Clinic. And the first point to make here is we intentionally have co-created a model with our now 82,000 employees. It is possible with many models that are out there to take one off the shelf and say, this is what we're going to do at our institution. We think that's actually a mistake, because well-being is experienced at the local level and engagement and active participation is essential. Every organization, every practice, every company has its own culture. And you can't simply take what works in one area and cookie cutter that into another organization. There are themes, we'll see those in a moment, that are going to be common across all of this. But you need to engage the voice of all of the people who are involved if you really want a robust strategy that people feel shared ownership in. As we went through this process of collecting input to marry the evidence base with what our employees told us, there were a number of key themes that emerged. And again, these are common sense. The first was that employees are actually our organization's most valuable resource. It's not our culture, it's not our leaders, it's not our benefits, it's actually not even our patients, which is somewhat sacrilegious. But in fact, our ability to serve our patients is delivered by our staff. Our staff are who honor the mission and the culture of the organization in service of patients. Privilege is a two-way street. So at a healthy organization, people feel it's an honor to work at that place. They don't often feel that reflected back at them. And very talented individuals bring their work by choice to a company or to a healthcare organization in healthcare. And so that healthcare organization should remember it is a privilege for those individuals to have chosen to bring those skills under their roof. Being cared for and valued is essential, and well-being means being supported in achieving each employee's greatest desired potential. This came from our staff, but it aligns really well with my own holistic well-being definition that I shared at the beginning of this talk. This then eventually led to, after a number of iterations, a mission and vision statement and a strategic model. The mission is to inspire and cultivate a workplace culture where we care for one another. Each individual experiences personal and professional fulfillment, and employee well-being is a foundational priority. The vision, thinking forward, is that Mayo Clinic models a values-aligned culture where all individuals have the support necessary to thrive, and we do what we do best. We provide compassionate and exceptional care for our patients and for each other. Importantly, not only was this mission and vision developed in partnership, in collaboration with our staff, it was publicly and has been publicly endorsed by our CEO and CAO, along with the rest of our top leadership teams. So this is a visible statement about what we are pointing toward and holding ourselves accountable to as an organization. Our model is oriented around what employees should expect to experience in the environment. They should expect to experience a healthy work environment, personal enrichment, community at work, being valued, and meaningful work. At the center of this visual, there are the levels of responsibility, which include individuals and what we bring to the table ourselves, teams and work units and how they function, leaders who help set the stage and create the environments to promote well-being, and then advocacy at an organizational level. How do we decide on our organizational policies, and how do we advocate for change across the entire healthcare landscape? These are built out further, and I'm just going to give a little bit of a teaser. A description of our approach and our model is actually in press right now at Mayo Clinic Proceedings and should be out in March. So if you want to make a little mental note, feel free to email me or look for that later in March. You'll be able to read about all of this in much greater detail. But what this has allowed us to do is start thinking about well-being with a slightly different matrix, where we have levels of responsibility and we have our 5 strategic focus areas. And we can start taking all of the individual ideas that already have existed across our institution, in addition to new proposals, and start mapping them to each of these areas. This can look different for every organization, for every company. But to give you an idea, healthy work environment at an institutional level. We have advocated at the state and national level for improving credentialing and licensing language. We have partners in this, the Lorna Breen Foundation and others, but we have successfully changed medical licensure language in the state of Minnesota to no longer ask inappropriate and illegal stigmatizing questions about mental health or other health issues. And we just passed a law that has gone into effect in Minnesota that doesn't allow such questions for any licensed health professional who requires ongoing credential. So this is huge in promoting help seeking and reducing the stigma around dealing with human challenges in the work that we do. And it's central to that Mayo Clinic level of responsibility and influence. At the individual level, we have opportunities for personal skill building and development. Dr. Amit Sood, who worked at Mayo for many years and now has an international company, focuses primarily on individual approaches for positive coping strategies and positive living efforts. And we have partnered with Amit integrate this into something that is available for every one of our 82,000 staff across the year in enduring ways and with remote access. Community at work, we have many team building activities and links online to that, and so on down the list. We've also created a website which is oriented around the user. So a website is not a solution, but it can provide a front door for people to connect with the solutions. And so if you're an individual at Mayo Clinic, effective last week, actually, rather than going through a maze of resources with a somewhat non-intuitive organization to try and find what might help you, you can at least start here with saying, hey, there's a drop down. I'm interested in this from an individual standpoint. And then I can start organizing in the structure down from there. If I'm a leader and I want to know more about how to create an environment for other people to thrive, I can click on the leader drop down. It will take me to toolkits and other resources to help me think about this from that perspective. So it's a user or persona focused way of helping people connect with whatever the pathways might be that align best for their needs. Again, at the center of all of this, however, are the MVPs of well-being, with everything we do intended to promote the ability for every member of our staff to connect more with meaning, values, and purpose in the work that they do. Our job is to facilitate and amplify those solutions and allow people who are already giving of themselves and want to help other people to connect in the best way possible to deliver on those objectives. We help our people take care of our mission. With that, I'm going to repeat my contact information here. Please feel free to reach out with any comments or questions, but I'm going to stop sharing there and open up to other questions and comments with the time that we have left. Thank you all for your attention and for all of the work that you do in whatever field you work in.
Great. Thank you, Dr. West. There's a few questions that have come in, some at registration for the event in itself. And I think you touched on it at the beginning, but what are some of the data that you folks are collecting, to demonstrate, hey, are these efforts working, or where can we do better at? Like I said, I think you touched on some of that at the outset, but
yeah, well, so
the well-being index, is that the primary tool you use?
So we actually we have the well-being index available. We have some other internal institutional offerings. One of the reasons that we don't use the well-being index across the entire institution is at this point, it doesn't include every job role with benchmarks. So we do have some more expanded kinds of assessments. But assessment really has two kind of broad levels to it. And the first one I don't want to diminish. And that is, if you align your interventions with a framework that is itself evidence-based, the mandate for you to show that you're moving the needle on those outcomes shouldn't be as restrictive, because you're already building this on an evidence base that, yeah, these are the things that we know work. And so if people say it's helpful, then that vibe has value because it's grounded in measurement that people have already done in the past. The second piece of this is, yes, you can also assess more objectively. There's a whole science around large scale assessment. You need these survey tools to be non-intrusive. They need to be safe. They need to be relatively brief, which is a challenge because a lot of these psychometric tools can be really long. And so we do assess burnout regularly using some abbreviated 1 or 2 item quick pulse checks. We assess belonging with a single question. That's new in the last year or two as that's become more understood. We ask about the attitude that our staff have to whether Mayo Clinic supports their well-being. So do they feel like we actually care? Because sometimes those are leading indicators of whether we're able to deliver what we hope to deliver. If people don't think that we actually care about well-being, it seems very difficult for us to think that we're really going to be doing something effective. I would refer people that are interested in measurement in greater detail to the National Academy of Medicine website on clinician well-being. They have some pragmatic measurement recommendations with specific tools. And feel free to reach out to me if you have additional questions about some of the specifics.
I think what might be useful too, and maybe we'll follow up after the presentation, Dr. West, is, those specific work-life balance questions that Mayo is asking. Those might be useful. I know just technologically from our perspective with our managed wellness platform, we have the ability to administer a survey or an assessment like that, and so that might be useful for some of the attendees as well. We'll get those. How do you made a point that really resonated with me, and that was when you rolled out this initiative. I mean, the head of the organizations, the CEO, CIO, essentially endorsed it, and we recommend that all the time with our clients with respect to their own wellness initiatives, and we don't think a lot do it. But that being said, you had to have come across department heads that were resistant. And do you just bring them along, go along to get along, or do they eventually warm up to it, or is there accountability somehow for those folks?
Yeah, this is a great question, and I think how I've approached this has evolved over my career as well. I think I was a little bit more, I won't say aggressive, but I was a little bit more in people's face about you need to see the light on this early in my career. And I don't think that was optimal. And the reason it's not optimal is my experience actually, as you get to know leaders who often have get a bad rap, is most leaders want their teams to do well. Sometimes they don't know exactly how to get there. But very few people, in my experience, get up in the morning in a sort of stereotypical Mr. Burns way from The Simpsons and, put their fingers together and think, how can I make everybody's life miserable today? They have objectives that are about a larger way of advancing a company or a healthcare organization in service of some larger mission. And so I think approaching people rather than, why don't you get this? You need to do this. You need to correct your behavior. And instead, from a point of shared understanding of what are your objectives? What do you hope to accomplish as a leader for your teams? And you allow people to reflect themselves on, I want a team that is cohesive. I want a team that's productive. I want a team that is effective. Well, what are the things that contribute to your team being able to deliver those objectives? And oh, by the way, they'll make your job as a leader more fun too. And then you start getting a little bit of, oh, this is a tool to help me as a leader. It's not a threat to my existence as a leader. And that becomes a subtle frame shift where suddenly you have, well, yeah, of course I want my people to thrive. And I can actually be a change agent that people see as contributing to that. Tell me more, as opposed to digging in the heels and say, yeah, that's great, but I don't have time for it.
Right. Yeah, I'm not happy until you're not happy. So, right. So again, Dr. West, thank you so much for your participation.
Absolutely, my pleasure. Look forward to dialogue and being part of all the great work that all of you are going to be doing in your environments as well.
Great. Take care.